All right, good afternoon, everyone. We are starting this Irish Symposium session. Beside me, there's Professor Pat Murray from UCD Medicine. He's co-chairing with me this session today. I will also be one of the speakers because the invited keynote speaker couldn't make it today. But before starting, I would invite the VP for the Irish Association of Pharmacologists, Cormac Kennedy, to give an opening on our association.
Thank you, Monica. So I think I have a relatively straightforward job, which is to introduce you to the Irish Association of Pharmacologists as Vice President. So we're a small organization. I think we have a few slides maybe coming up, but founded in 1990. By Professor John Feely, who was based in Trinity and St. James's. And his vision that we would have this organization that would strand across basic clinical pharmacology and now prescribing is very much part of that discussion as well. And we have a meeting once a year. I suppose reinvigorated recently by Monica as the president and supported by the BPS, and that's gone from strength to strength. But it's a lovely meeting each year in November, whereby our trainees and our PhD students, postdocs, can chat with each other and with other leaders in the field in Ireland. So it's a lovely meeting, and everybody is very welcome. That support this year, we had Mark Evans, who came over and again took part in that day. So we're very appreciative of the BPS and their support of that meeting each year. Today and this week, we've been part of this meeting. So we're again very, very grateful to the BPS for inviting us to come on board this event. I think it's really, really successful. So congratulations to all of those involved. And I'd particularly like to thank our executive and Monica, who's done a huge amount of work here, including putting together a keynote talk at the last minute. So really looking forward to that. But she's really driven on the organization, and congrats to her. So looking forward to the session. Thank you.
So up next is our sponsorship. Camilla from Genuitz is the only thing the slides appearing. They are not the correct one. This is for the next. I'm not sure if we checked that they received it. In the meantime, I might give a bit of a background of our chair here, Professor Pat Murray, because it's a real honor to have it here. So we are very grateful for him to travel to Belfast for chairing this session. So Professor Pat Murray is a full professor of clinical pharmacology at UCD and a consultant physician at the Mater Misericordia University Hospital in Dublin. He received his medical education at UCD. Following an internship at the Mater Misericordia University, he completed a residency in internal medicine at Hennepin County Medical Center in Minnesota. During this time, he completed fellowship training programs in nephrology, critical care medicine, and clinical pharmacology at the University of Chicago Hospital in Chicago. Professor Moore is a board-certified in nephrology, critical care medicine, and clinical pharmacologist. He has practiced as an intensivist, nephrologist, and clinical pharmacologist at the University of Chicago from 1996 to 2008, serving as the Fellowship Training Program Director in Nephrology and also directing the acute dialysis service. He also has a long-standing interest in research and education to improve the prevention, diagnosis, and therapy of acute kidney injury and nephrotoxicity, and the pharmacotherapy of patients with kidney disease. He's the chair of the Mater Misericordia University Hospital Drugs and Therapeutics Committee and clinical director of the UCD CRC Clinical Research Center. In 2011, he was appointed Associate Dean for International Affairs at UCD School of Medicine. In 2012, he was appointed Director of the Dublin Center for Clinical Research Consortium Network, and he had served as Dean and Head of the School of Medicine from 2012 to 2018. So a round of applause for Professor Mori that is here.
Thank you, Monica, and I apologize for you having to listen to all that. We do not have the slides for Camilla Laidlaw, so we'll make time later in the session.
Yeah.
But for the moment, I'll go ahead and introduce our keynote speaker, who stepped in for Conal Dennedy, who unfortunately is quite ill and wasn't able to make the meeting. Dr. Monica De Gaetano is an assistant professor in pharmacology in the School of Biomolecular and Biomedical Sciences in UCD. She is also current president of the Irish Association of Pharmacologists. Her research is based in the Conway Institute in UCD in Belfield, and she has a long-standing interest in resolution pharmacology. And you can see the title of her presentation is along those lines, looking at resolution of atherosclerosis by treating low-grade inflammation. So Monica, it's a pleasure to be here, and thank you so much for stepping in to do this at short notice. It's much appreciated.
Thanks, Pat, for the nice introduction. So I feel honored to, I've never been a keynote speaker before, so you never say never, ever. When you don't expect, things happens as always. And because we are approaching to the end of the year, the title of my talk is about the New Year's resolution that in December we do for the coming year. And in my case and for my research is to hoping to get sooner rather than later some resolution pharmacology drugs that can tackle better the low-grade inflammation that is underpinning atherosclerosis. So before, as a keynote speaker, I would like to introduce a little bit of myself and my journey in Ireland, especially because now I'm representing Ireland as the president of the IAP. So this was established in 2009 when I moved from Rome to undertake a PhD scholarship under the supervision of Professor Ina Belton in the resolution of inflammation in atherosclerosis. Then I did a long postdoc training under the supervision of Professor Catherine Godson, and I joined the Diabetes Research, Complication Research Center at UCD. And now I'm a PI in this center working on the macrovascular complication of diabetes. And instead, this is shorter than my time at UCD, which is almost 17 years. But over the past few years, I've been member of the association, and only recently, in 2023, I was appointed VP, and this was happening in Cork at their annual meeting in that year. So that picture of me and my group celebrating the good news. And then last year at RCSI, the past president, Christian Weber, passed the baton to myself as president. So now I'm in the middle of my 2-year term of presidency. So why I'm so interested in cardiovascular disease research and pharmacological research in particular? Because it's the most prevalent global cause of death worldwide, more even than all type of cancers. And if you look at the numbers and figures of the death toll per year worldwide in Europe, in Ireland, and in Italy, which I'm particularly fond of, that's very impressive and scary. And also, as pharmacologists and clinical pharmacologists or drugs developers, we are also interested in how this impact at the economical level, so the economical burden associated with that. We refer to the big impact in America, but also in Ireland, and especially in the last 2 decades, and is foreseen again in the next couple of decades to increase predominantly. The good news is that overall cardiovascular mortality in the last 50, 60 years is declining. And this is because of the identification of risk factors, and most of these are preventable, so this is the good news. And also, as pharmacologists, is thanks to the work of some of the fathers of the pharmacology, like James Black, and others, that over the 50s and 60s in the past century, they have discovered these big molecules, big molecular targets and receptors through which some of the main risk factors identified in the 50s through the Framingham studies, like hypertension and hypercholesterolemia, could start to be treated. More recently, we are looking at cholesterol reverse transport. We are still relying on statins mainly, despite they have been launched on the market in the 80s. In Ireland, they are still one of the most prescribed drugs. But more recently, we know that we can also target hyperlipidemia not only with statins, but with the PCSK9 inhibitors, although it's still an elective treatment due to the associated high cost. So currently, atherosclerosis and cardiovascular intervention are mainly treated, as I was saying, with lipid-lowering drugs, in particular statins. There is a bit of shift to repurposing glucose-lowering drugs, as well as anti-inflammatory therapy, thanks to the work of the Cantos studies and Paul Ridker. When therapy fails or is not enough, we still rely a lot on the surgical intervention, which is quite strong and invasive, through stenting or endarterectomy or bypass surgery. So the limit of this is that the drug therapies that we described have still present for some category of patients major side effects. If you think about the myopathy associated with the statins or the important weight loss of GLP-1 receptor agonist. The downside of the Cantos studies and the SEER trial shown the immune suppression associated with the prolonged and strong anti-inflammatory therapy. So this makes the rationale for having something different, which is as well anti-inflammatory, but not completely abolishing the ability of our immune system to respond. And so this basically is the background towards resolution pharmacology. So before understanding resolution, we need to have a bit of idea of what is inflammation in itself. Has been described for a long time from the Roman times because of the visible cardinal sign, which are heat, redness, swelling, and pain. And then much later on, also the loss of function was described. More recently, we are interested in understanding how to stop inflammation at molecular and cellular level, not just at the macroscopic level. And we have understood that molecules that drive the onset of inflammation has been quite characterized, but there are not only the on switches, but also the off switches are as well as important. And in these particular settings, we look at the specialized pro-resolving mediators. In particular, my work is focused on the lipoxin family. And in particular, I work on the macrophages, which are one of the main immune cells producing this family. So the resolution pharmacology has been driven by Charles Serran, that I'm sure everyone in this audience have heard of. He described beautifully how this switching class and switching lipid mediators develops during the normal process, the various phases of acute inflammation. So we have a trigger, and we have, after hours or days, also the cellular players are changing. It's not just the neutrophils arriving to the tissue, inflamed tissue, but then also monocytes and macrophage plays a role. Initially as a M1 pro-inflammatory, and after this lipid mediator class switch, they change phenotype and they turn into M2 resolving macrophage, and they start reducing the production of eicosanoids and increasing the production of resolving molecules. So I'm very happy that just 2 months ago, I had the honor to have a lunch together with Catherine Godson and Owen Brennan in Dublin with Charles Serran, that was traveling for a conference, of course, was an invited keynote speaker. So as a novel drug target in the resolution of pharmacology, of course, the GPCRs are one of the favorite molecules, and in particular, among the SPM receptor, we have these classes which are FPR2, GPR32, GPR18, ChemR23. As I said, for my particular work, I'm mainly interested in lipoxin A4, and so I'm mainly targeting the FPR2 lipoxin receptor, which is a receptor that is abundantly expressed by classical and non-classical immune cells. It's also a particular receptor because it's promiscuous and exert different ligand-depending effects. But is the target of the resolution of inflammation, so this doesn't have to be confounded with Republic of Ireland. With all this work initiated by Charles Serran, but also other groups, especially in Ireland, in Italy, and elsewhere in Europe, we can now redesign and reshape inflammation, looking at also the important pillars of resolution, which are highlighted here. So why this is so important? Because if we don't resolve acute inflammation, over time, we may end up in scarring, fibrosis, ultimately chronic disease and organ failure. And so this is the basis of the common soil across the most prevalent chronic inflammatory disease. And in particular, I'm looking at atherosclerosis for my research. So why this is so important in atherosclerosis, why is crucial the role of monocytes and macrophages. As you can see from this diagram, it is clear how the influence of the microenvironment in the subintimal layer dictates either the resolution, the spontaneous resolution, which is the slow progression, or even the regression of plaque formation versus the chronic inflammation, plaque development, and also complication like thrombotic complication and so on. We mentioned the critical role of macrophages, but over the last few years, we were biased to just describe everything like M1 or M2, like black or white. We now know, and this is just to the most of our knowledge, but for sure this is an always ever-changing landscape. We know that there is a plethora of macrophage, M1, M2, and maybe even other numbering of macrophages that are characterized by different phenotypes. And we also know that on top of this, this is not just dictated by hyperlipidemia and inflammation, but also hyperglycemia plays an important role. And so in the more recent years with my second PhD student, I'm looking also at the critical role of insulin dysregulation in exacerbate what is already a necrotic and inflammatory process. So the hypothesis behind my research is if we can target low-grade inflammation and sustain inflammation to treat atherosclerosis by reprogramming the macrophage phenotype through their plasticity. using a pro-resolving therapy. So eventually having an efferocytic macrophage that is able to clear the debris and the dead cells and the excess of lipids from the endothelial space. I mentioned the lipoxin A4 family, but unfortunately we know that there are limitations to make these straight as a drug because it would be very costly and time-consuming to synthesize on a manufacturing scale, also because of the in vivo instability. So that's why, in collaboration with Professor Pat Gairy in chemistry in UCD and Professor Catherine Godson, we have established a series of family of lipoxin A4 mimetics, playing with the scaffold of the lipoxin structure, as you can see here, by making more stable, by modifying purposely the hot spot for redox that makes very unstable the molecule. And so we could make various classes of mimetics by changing these various areas. So this was my postdoc main project, to screen from a biological evaluation the efficacy, potency of these various families. So I set up this in vitro platform. It's not robotic, so it's not that much high throughput, but we were able over the time of my postdoc training to screen over 30 compounds across 5 heteroaromatic categories. In vitro first, we identified some hit candidates that we then validated through international collaboration in various in vivo studies. And we eventually patented 2 of these molecules, which for short are attenuated therapeutics, which is the spin-off that we have created at Nova UCD, KG and CT, which are simply the initial of the names of the chemistry student, PhD student from Pat Gairy that designed the molecules. So here I just want to show quickly the highlights of this screening program, because has been taken a lot of time, of my time with Catherine's money. So you can see we were always referring back to the parent compound, lipoxin A4, and this KG and CT compound, where you can see this is how they reduce NF-kappa B-driven inflammation. And so they are more potent and or more efficient. But they also induce, so this highlights an anti-inflammatory profile, and this is more shifting towards a pro-resolving phenotype because they are enhancing the phagocytic capability of these macrophages. From a mechanistic point of view, we wanted to understand if FPR2 played a role in this, and we could see through a calcium release intracellular mobility assay that they were activating the FPR2 receptor, and they were equipotent partial agonists of the FPR2. So this is some of the validation in vivo that we have done in Trinity College in Porek Fallon lab and in Queen Mary with Mauro Perretti's lab. So this is an acute inflammation zymosan-induced peritonitis model, and we can see the reduction of PMN infiltration in the peritonitis of these mice after injecting these compounds. And this through another collaboration with Derek Gilroy in UCL, we have another model of acute inflammation, the carrageenan-induced poedema. And so here we see the accelerated time of resolution. And then in-house with Dr. Owen Brennan, we have developed an ApoE knockout murine model of STZ-induced diabetes. And so we could see that in the aorta of these mice, you can see the reduction in the redness, in the red spots of plaque, atherosclerotic plaque in the mice. They are reduced with the use of the lipoxin and the benzolipoxin, as well as characterization of some inflammatory biomarkers being significantly reduced in these mice. But for as beautiful it is, the in vivo model, we know that doesn't completely translate with the human complex body. So we needed a bit more translational models. And that's my lab, my squad that is here and has presented talk and poster these days about their work. So I'm very blessed to have in my lab Braden, Luke, and Kieran, because they are very thoughtful and highly knowledgeable. So this, in a normal day in the lab where Braden is combating hyperlipidemia, Luke is fighting hyperglycemia, and Kieran is always controlling the level of inflammation in our environment. So thanks to clinician collaboration in Mater Hospital and St. Vincent University Hospital in Dublin, we are making a biobank of these atherosclerotic human plaques post-endarterectomy. And so this is how they look at a gross macroscopic level. And initially, when I was still with Dorina Belton, I was characterizing by histology the development and the difference between asymptomatic and symptomatic plaques, also at gene and protein level. But now what we want to do is to be able to run an ex vivo study to treat out of the body these pieces of plaques with our candidate compounds and see what's happening. And so Braden and Kieran has developed together a novel protocol to maximize the output from very teeny tiny pieces of tissue to get from the exact same tissue both RNA and protein. And while we were here these days, we submitted this paper at the Bioprotocol Journal, so hopefully this will be published soon. And this was the great optimization work that Kieran has done. If people here is working with tissue, may know how difficult it is to get a clean Western blot. And so here we can see the total protein, how has been improved after optimization. And this is using plaques. We also checked this method in other tissue, mouse aorta and THP1 monocytes. And this is how we can clearly have a clean target protein. And we can see that across three randomized patients, we have the same trend, but we can also assist to some inter-individual variability. Braden, with these plaques, analyzed at RNA, mRNA level, the expression, the responsiveness of this necrotic, so almost dead piece of tissue, which actually they are necrotic, but they are still alive up until at least 48 hours, but we want to challenge this even further in the coming months. And so you can see that if you stimulate ex vivo with TNF, they do respond by increasing at mRNA and cytokine level with the classical inflammatory markers. And then we treated as well with the lipoxin A4, and they were, some of these were remarkably reduced. So next, and in collaboration with Ginny, with our sponsorship, we are soon trying to get no-link proteomics as well as RNA-seq of these teeny tiny pieces of tissue. So we also go back to our in vitro work, and this is basically Braden's PhD project, to look at this plasticity of macrophage in the context of atherosclerosis, but we wanted to make as much translational as possible. So instead of using the outdated PMA and forcing in a not very natural way these monocytes to become macrophage, we really mimicked what's happening using the endogenous growth factor, MCSF, CMCSF, and then polarizing with a variety of stimuli to get the plethora of subphenotypes and finally tuning and characterize each of them at RNA and protein level. And so this is one of the highlights of the RNA-seq on this THP1 that Braden has done, and we have highlighted the importance of some of the migratory genes as well as lipid transportation. And so for lipid transportation, it's also important the uptake, the influx and efflux of cholesterol from a macrophage, because if this is prevented, they turn into foam cells. And so we were able to characterize all these in vitro, and very soon we will test on this model as well, the lipoxy mimetics. Then we highlighted the importance of migration. So here we can see how these specialized pro-resolving mediators reduce monocytes infiltration towards MCP1, as well as towards plaque condition media. And as well, and interestingly, in the macrophages, it looks like to doing the opposite, so in enhancing this migration. We don't want to speculate, but we think that this might be a different type of migration, which could mimic the e-migration out of the plaque towards the lymphatic system. We also want to check the combined therapy with the lipid lowering. So at the moment, we only have data on the statins themselves, but the next step will be to combine lipoxy, mimetics, and statins and see if they are adjuvant of each other. I mentioned the importance of hyperglycemia. So Luke, in my lab, basically enhanced and progressed Braden's model by also exposing persistently over time these monocytes and macrophage to high level of glucose, which is 25 millimolar. And as well characterized by RNA in vitro, this diabetic macrophage. And we saw, for example, some interesting hits that high glucose in the first instance decreases CD163 and MCP1 while increasing TRAIL, and then lipoxin rescues CD163 and enhances TRAIL and MCP1. Of course, we have to validate this functionally, but this may suggest a switch in phenotype towards resolving macrophages. We also looked at cytokine release in for low, we intended the normoglycemia, the 5 millimolar versus the high glucose environment, and see again that lipoxin enhances some of the inflammasome-related genes, but high glucose prevent the action of lipoxin. And so we think that maybe lipoxin by itself is not enough in a high glucose challenge model. So the next step is to combine with liraglutide, so the glucose lowerings, this compound, but I still don't have the data for that. Luke has also started characterizing the glucose challenge monocytes and macrophage by looking at the mitochondrial activity and glucose consumption, as well as the migratory ability of these monocytes and macrophage towards MCP1, which is a classical chemoattractant for monocytes, and the plaque condition media, which was having access to these plaques. We wanted to have a media that's been exposed for 24 hours to these plaques and use as a chemoattractant. So it's a much more attractive cocktail. And so towards PCM, this plaque condition media, we see that glucose enhances the migration, but lipoxin reduces, whilst liraglutide alone and in combination is not following lipoxin, basically. Just to mention briefly, because this is just coming from a UCD seed funding award that I received, we want to explore in parallel the ability of encapsulating in nanoparticle delivery system these unstable lipoxin A4, or even to enhance the properties of the mimetics. And so in collaboration with mechanical engineering in UCD, they developed this device to encapsulate in lipid-based nanoparticles the lipoxin. And at the moment, we're simply characterizing the nanoparticle shell and their content and the encapsulation efficiency. And we have some preliminary data that at least show that lipoxin alone and encapsulated have a very much similar gene profile. So I want to conclude with my reflection on the resolution pharmacology, so where we should be and where we are at. So the ideal drug would be a drug that blunt the inflammatory response, but also activate the resolution reprogramming. So at the moment, this doesn't exist yet on the market, but with pro-resolving candidates that in the lipoxin family and resolving family has been identified, or down the line, this could be a reality. So So I just want to conclude by acknowledging again my lab, but also my mentor, in particular Katrin Gotson and Norina Belton, and we couldn't have done all these lipoxymimetic works without the collaboration with the chemistry, so Pat Gairi, and then all the other collaboration here in UCD and in Italy. So thank you for that.
Thank you very much, Monica, for your lovely presentation. Do we have questions from the audience? And if we do, will we be able to see anybody? Because we'll need to call for a microphone. Anyone? Okay. We don't have anything online either. I'm going to start with a question. Maybe someone will come up with something. Is there a broader literature looking at the SGLT2 inhibitors or the GLP-1 agonists as far as effects on atherosclerosis? Because it's kind of interesting that particularly the SGLT2 inhibitors, they can't do a negative trial.
Yeah, it's more at the end of the process. So we know that it's cardioprotective, but we don't know exactly how some of these drugs that have been repurposed. So now what we want to try, in our case with the GLP-1 receptor agonist, is to try and identify which is the receptor, because on monocytes and macrophages, this is not highly expressed. So our hypothesis is that drugs like liraglutide or semaglutide can have an influence on the immune cells, but through other receptors, which could be maybe the SPM receptor or other receptors. So the mechanistic view is still not known.
And is there, for instance, sodium-hydrogen exchange in atherosclerotic plaques?
I would say so, because of especially in the endothelial level, maybe not much on monocytes and macrophages, but I'm not an expert on that.
That's interesting stuff. Any questions? If not, I'm going to ask you my favorite atherosclerosis question. We see so much atherosclerosis in diabetics, non-diabetics, in obviously the lower extremities, the neck, all through the aorta. We almost never see symptomatic atherosclerosis in the upper extremities. Why is that?
So we have access to carotid and femoral plaques, and I can already see there is a huge difference at macroscopical level between the two in terms of size. The carotid are much more smaller. The femoral can arrive to 7-8 centimeters. And also the content is completely different. The femoral is almost impossible to work with because they are literally piece of rock. Instead, the carotid one are relatively tender, even if some of them are more calcified than others. So definitely the location in the body makes a difference. Now, why we don't have on the upper limbs, I don't know, but I might speculate that I don't know if it's about the blood pressure. I'm not sure.
It's a hard one to answer because you don't get the samples.
Exactly.
Because they don't have the disease. Okay, I'm not going to bring up any more mysteries. Anything else from the audience? If not, we're doing well on time. Is there a question, perhaps?
Hi, thanks very much for the talk. I'm just wondering, would you expect would semaglutide be a better candidate rather than liraglutide from a receptor binding perspective?
Yes, that's our next on our schedule. We just started from something that we have previously tested in the lab, which is liraglutide. So at the moment we are mimicking what we have done before, but the next step is to move to semaglutide.
And just in relation to the topic of upper extremities versus lower extremities, I wonder if one of the factors could be potentially a greater proliferation of smooth muscle cells in the lower extremities due to higher hydrostatic pressures that you experience, and as a result, given the involvement of smooth muscle cells in the process of atherosclerosis, that could be one of the explainable factors.
Yeah, it could well be because the migration of smooth muscle cells between the media and intima plays a role in the development, so it might be.
Whereas you don't really get that with the upper extremities.
Okay, good to know. Thanks.
Okay, I think we have time if we have Dr. Laidlaw's slides for brief presentation. Thank you, Monica.
Thank you very much for having me. Today, I am very briefly going to introduce myself and GeneWiz from Azenta Life Sciences, and hopefully inspire you a little bit about what options are available to you starting from a single sample. Very briefly, GeneWiz is a multi-omics service provider. We read and write DNA. I quite like the sort of scaffolding imagery here. And we support with research, discovery, as well as preclinical testing with higher regulatory environments required, and clinical with validated assays available. This slide I always find very overwhelming because we offer so many things. So I thought a nicer thing would be to discuss a little bit about what you could do with one sample. So we have this challenge where a client was looking to test for an IBD drug, and they were looking for novel biomarkers, and they wanted to understand mode of action with a multi-omic approach. You have samples from across the world, in this case, requiring to be brought to one place and worked on there. So how can you support that? Well, we are able to, within 24 hours of whole blood extraction, fractionate the sample and extract as required. And it allows you to interrogate your sample across various omic technologies, from genomic, where you're looking at the genome level, or epigenomic, transcriptomic, single cell options, as well as now proteomic profiling. Here, this customer decided they wanted to go for the genomic approach with transcriptomic along with immunoprofiling, and proteomic analysis with HT from Olink. And this was all from a single blood draw per patient, where we sorted thousands of samples and delivered projects on time to a high level. One of the technologies I've mentioned, and I heard Monica mention, was Olink proteomics. It's a really powerful new technology. It allows for the integration of your data with other multi-omic approaches and direct protein analysis. They provide panels across different diseases, as well as more discovery type panels where you investigate into thousands of proteins. And you can start with basically any kind of sample, any kind of liquid sample. And just to brag, we were selected for the very prestigious FinGen project to deliver 10,000 Olink with the Olink HT panel. So far, we've processed 50% of those samples, and we are smashing our QC goals, which is something I'm really proud of. Not just being able to deliver such high throughput assays, but to deliver them at a high level is really important to us. So finally, I want to just thank you again for your time today. And if anyone wanted to speak to me, there's a QR code there. Feel free to reach out, and I wish you all the best for the rest of this conference.
Thank you very much. Very good. I'd like to now introduce our next speaker. Dr. Katrina Kerr is a senior lecturer in the Data Science Centre, School of Population Health in the Royal College of Surgeons in Ireland. Katrina holds a PhD in health services research and a higher diploma in psychology and economics from Trinity College Dublin. She has an interest in researching in quality, safety, and adherence to medication in primary and secondary care settings. And her title is The Scope and Nature of Potential Medication-Related Harm in Older Populations in Ireland.
Great.
Welcome.
Thank you. Good afternoon. I'm very delighted to be here today to talk to you about our research. I do apologise in advance, I'm losing my voice, but hopefully it'll hold up for the talk. So just to give some context to the research we're doing, as you're probably all well aware of, the World Health Organization launched its global patient safety challenge a few years ago, with its aim is to reduce severe avoidable medication-related harm by 50% globally in the next 5 years. So in order to address this challenge, we are awarded funding from the Health Research Board in Ireland to assess the scope and nature of medication-related harm in older populations in Ireland, in partnership with the HSE National Quality and Patient Safety Directorate and University College Cork as well. So we're of particular interest in terms of looking at the scope and nature of medication-related harm. We focused in on adverse drug reactions and adverse drug events, and then kind of more generic kind of adverse health outcomes, including things like hospitalisation and quality of life and functional impairment in older people. There were a number of investigators and collaborators who were involved in this work. I'm not going to name them all today, but just to highlight that it's been very much a team effort. So our kind of two main objectives for this work were really, firstly, we set about to determine the prevalence, the characteristics and risk factors associated with ADR-related hospital admissions among older people in Ireland. And then from this, we wanted to develop and validate risk prediction tools that identify older people at risk of ADR-related hospital admissions and adverse drug events and other kind of forms of medication-related harm. So firstly, we set up the ADAPT cohort, which was the adverse drug reactions in ageing population cohort. This was a cross-sectional study of ADR prevalence in all patients aged 65 years admitted acutely to a hospital in Ireland over an eight-month period. And then we had a follow-on prospective cohort study of patient-reported health outcomes and costs associated with these ADR-related hospital admissions. So all patients admitted to hospital were screened for a suspected ADR on admission within the first kind of 36 hours of admission by the research team. And this screening included a multifaceted review of each hospital admission to assess the likelihood of the ADR being a reason for admission or cause of admission or contributing to the admission in the context in terms of the patients, their medications, their clinical conditions, medical history, etc., and investigations. And then we applied a number of decision aids as well to assess the causality, the preventability and severity of the ADR. And then we also recruited a random sample of patients who were determined not to have a suspected ADR on screening as our control group. So in terms of our findings, 3,760 hospital admission episodes were screened, and we found that we did 10% prevalence of ADRs. Of these admissions, 58.1% were caused by an ADR, and the majority between 66 and 77% of ADRs were deemed to be possible. 43 or 11.4% were deemed to be definitely preventable or avoidable, and then in total 92.8% were classified as being of moderate severity. So we then looked to have a look at the characteristics of the ADRs and to try and establish what drug classes were associated with the ADRs. And we found that anti-thrombotic agents were associated with 33% of these ADR-related hospital admissions. And then this was followed by our cardiovascular system drugs, ranging from 6% to 32% of ADR-related admissions, respectively, and then our psychoanaleptics after that, which accounted for about 6% of ADR-related hospital admissions. We then looked to see what risk factors were associated with our ADR-related hospital admissions, and on screening we screened for a number of potential risk factors, including socio-demographic-related risk factors, functional ability-related risk factors, disease-related ones, and medication-related ones. And then we looked at the association between these risk factors and ADR-related hospital admissions versus our control group, our non-ADR-related admissions, using logistic regression. And what we found that was being immobile or frail, having delirium or ulcer disease, and taking an anticoagulant and antiplatelet medications and hospital admission were significantly associated with an ADR-related hospital admission. Well, we found things like older age and having a medical card or having fallen previously to be not significantly associated, or were significantly associated with not having an ADR-related hospital admission. So having done this, we then set about to think about what else could be associated with ADR-related hospital admissions. And there's a lot of evidence in the literature about the use of potentially inappropriate prescribing and their association with adverse health outcomes in older people. So we looked at applying the stop-start version 2 criteria and the 2019 Beers criteria. And we found within our cohort that 98% of our cohort had at least one potentially inappropriate prescribing indicator or prescribing inappropriate admission on hospital admission, and the median being about 5. So on this basis, we found that there was no association with having at least one or the number of stop or start version 2 or 29 Beers criteria and ADR-related hospital admissions. We then had to look to see maybe what potentially clinically important drug-drug interactions and the average causal effect of DDI exposure on ADR-related hospital admissions. So we established a list of 28,225 unique drug-drug interactions, which were classified as being both severe per the BNF and also as a red warning and orange warning per Stockley's. And what we found in our cohort that 40.4% of our patients or cohorts had at least one potentially clinically important DDI on admission to hospital. And within those who had a DDI on admission, 49.4% of our patients, almost half, of patients with this DDI had an ADR-related hospital admission. We found an average causal effect of DDI exposure on ADR-related hospital admission of 1.2 was our odds ratio. In terms of the interaction effect, the odds of ADR-related hospital admissions was significantly increased by exposure to DDIs, which carried a risk of bleeding. So having done kind of our groundwork per se, we then use this information to set about developing and validating a risk prediction model that identifies older people at risk of an ADR or an ADE. So 20 risk factors were chosen for consideration. So we chose those based on our initial findings in Objective 1, those that we found, risk factors that we found to be significantly associated with ADR-related hospital admissions in the ADAPT cohort, and then also ones that we identify per systematic reviews where there's evidence and strong evidence in the literature. And then also we chose risk factors that were practical, efficient, and easy to apply because we needed them to be of use in clinical practice. So in terms of developing the model, we started off with our standard univariate logistic regression, followed by our multivariable model with stepwise backward selection. And then our final model was identified based on the lowest value of the BIC. We undertook internal validation of the model using 5-fold cross validation. And then we externally validated our risk prediction model in a separate cohort, the Centre for Primary Care Research cohort of patients, in which case we were looking at adverse drug events. And then we looked at the standard criteria of the area under the receiver curve and calibration of the model. So what we ended up with a model which we've called Adapted, which contains 9 risk factors: age, chronic lung disease, the primary presenting complaints of respiratory disorders, bleeding disorders, gastrointestinal disorders and syncope as well, and the drug classes, antithrombotics, diuretics, and RAS drug classes as well. So in terms of our model, the area, in terms of the cross-validated model, the area under the curve was 0.75, which is quite good, and then an external validation in the CPCR cohort, the area under the curve was 0.83, and our calibration was adequate for both models. So it was a relatively good performance. Having done that, we then had to think about possibly what other types of methods could be used in order to develop risk prediction models for medication-related harm in older people. And we sought to use latent class analysis, which is kind of a way of identifying subgroups, or there are particular ways of identifying older people, groups of older people that are similar with respect to a set of observed variables or characteristics that may be more at risk of medication-related harm. So we set about to identify these groups, and we used our same risk factors as I've outlined previously. We looked at our kind of 7 high-risk drug classes per se, and also the other known risk factors in the literature like frailty and polypharmacy and multimorbidity, etc. And then in terms of our medication-related outcomes, we used our ADO-related hospital admissions again, but also we included health-related, the quality of life and functional impairment and emergency department visits, as well as other indicators of medication-related harm. So we set about to determine the best number of vacant classes and then undertook our regression models to examine the association between these latent groups that we identified and medication-related harm outcomes. So what we found that a 5-class model was determined to be the best fit, and in terms of our 5 classes, we identified 5 different classes, and based on, we named them the high-risk prescribing and polypharmacy group, the low-risk group, which is our comparison group, our high-risk prescribing only group, our antihypertensive group, and psychoanaleptics and polypharmacy group. And what we found that our older patients in both the high-risk prescribing and polypharmacy group and the high-risk prescribing only group were more likely to have an ADR-related hospital admission. And also the high-risk prescribing and polypharmacy group also had higher functional impairment. So in terms of, to finish up, where to next? So work is still ongoing. We need to externally to validate the adaptive model. We've validated in the CP0 cohort using ADEs, but we're also in the process now of prospectively collecting hospital data again and assessing the tool to establish further its validation. And we also want to compare it with other existing ADR and ADE risk prediction models to see how they all compare to each other. And then we're also going to extend our latent class model to look at how that applies to other databases and other cohorts. And just to say thank you for listening, and also to acknowledge our funding, the Health Research Board, and also all the other people who collaborated to this research.
Thank you very much, Dr. Kerr. That was very interesting. While we wait for questions from the audience, could I just ask you, I mean, obviously we all know we should be avoiding polypharmacy, deprescribing, being careful with high-risk medications. With what you've got in the score here, if you had to do an intervention guided by the risk factors, what would it look like?
We've been doing some work. Well, Ciara Kirk, who we work with on this work, has been doing some work with the iSympathy project. I don't know if you've heard about it. It is about looking at reducing polypharmacy in primary care through pharmacists' interventions, through detailed medication reviews. It has been shown to be quite effective, but it does take time. But it has been shown to be cost effective, so I think probably the most beneficial would really be intervene in primary care really before you end up being admitted to hospital, I think.
And in terms of the drug-drug interactions, I mean, some of the ones you've got there, you would think they'd be caught on the drug interaction software, but it doesn't seem to happen.
No, and I think part of that, I mean, a lot of prescribers will talk about alert fatigue, and particularly this cohort where you have people on, 15, 16 different medications, multimorbidity. It's quite difficult in terms of identifying and interactions, given the high prevalence of them.
Very good. Simon, I didn't see you in the audience there.
Yeah, that's right. I'm very easy to miss. But, well, Pat, you actually took one of my questions, but I was just going to ask, I mean, it's really great work, but although there are a lot of statistics there, I got the impression, actually, the number of avoidable adverse drug reactions look rather less than, a lower proportion than some of the previous studies where it's been about 50, 60, 70% in some studies. And I just wonder if you'd like to comment on that. I was also going to ask, obviously, about how we can avoid this, because I think it's an elderly cohort, and you're going to have lots of drug-drug interactions. You're going to have higher risk prescribing because you've got more vulnerable patients. But maybe you could comment specifically on the number of adverse drug reactions you thought were truly avoidable with more judicious use of medicines.
We did have a panel of reviewers looking at them, and it is, I suppose they were, it could be lower, it is probably lower than some of the studies in the literature, but I suppose it depends on the method as well. Like a lot of studies, some use databases, some kind of use just clinical judgment. So we kind of did a particularly thorough process of actually, using a number of kind of decision aids as well as clinical review, and a very kind of detailed analysis of patients' medical records. And given, I suppose, the context of that they were like a highly multimorbid population with as I said, 15, 20 medications, it's, in terms of, I think some things probably were deemed not, that they just couldn't be, the benefit of the medication would outweigh the risk, I guess. I don't know if that answers your question. But, yeah.
I certainly wasn't criticising. In fact, your percentage looks much more realistic actually than some of the other studies.
Yeah. And I think that's the only problem with a study like this is it's like, very labour intensive to actually really thoroughly look and identify whether that is actually an adverse drug reaction and to judge it. In terms of, scaling this up, I think we need to develop quicker, better methods, in terms of maybe like being able to use databases and do it more at a national or public health level.
Very good. Thank you very much for your presentation, Katrina.
Thank you.
So our next speaker is Dr. Andrea Kwakowski, Associate Professor in Neuropharmacology at the University of Galway and Program Director of the Neuropharmacology Master Program. Dr. Kwakowski research focuses on the molecular cellular mechanism underlying neurodegenerative disease, particularly Alzheimer's and Huntington diseases. Her work integrates studies using human tissue, animal models, and advanced electrophysiological and imaging techniques. In today's talk, she will discuss how targeting specific GABA receptors may help restore brain balance and improve cognitive function in Alzheimer's disease, offering possibilities for novel therapeutic strategy. Please join me in welcoming Dr. Andrea Kwakowski.
Thank you very much, Monica, for the kind introduction and also for the opportunity to present here today. I slightly changed my title. I'm going to talk about the treatment of amyloid beta-induced network dysfunction and cognitive deficits by targeting specific alpha-5 receptor subunit containing receptors in the brain. So, Monica, you mentioned that the leading causes of death are cancer and cardiovascular disease at the moment, and the third one is dementia. We are experiencing a dementia pandemic, and we have around 70 million people worldwide living with dementia, around 65,000 people in the Republic of Ireland, and these numbers are increasing. We had such amazing breakthroughs in cancer diagnosis, therapy, and for cardiovascular disease as well. The same breakthrough didn't happen in the field of dementia yet. We thought we are close to that when after the recent approval of monoclonal antibodies, but we know there is still much more work needs to be done. And also there are issues like delivering these therapies, and also in diagnosis and many other problems in our public health systems that preventing us to deliver these therapies efficiently. So a lot of work needs to be done. And so other type of drugs like acetylcholinesterase inhibitors and NMDA receptor antagonists, they are still being prescribed and they provide some symptomatic relief. And when we are talking about dementia, the main cause of dementia is usually Alzheimer's disease. It accounts approximately for 60 to 70% of the dementia cases. And it's a progressive neurodegenerative disorder which involves usually the difficulty in encoding and storing new memories. And when we are talking about dementia, that's an umbrella term. There are some common features in all different types of dementias, and this is significant neuronal loss, neurodegeneration that leads to memory and thinking problems called dementia. Besides this, we also see neuroinflammation and vascular dysfunction, but also significant neuronal network dysfunction. At the moment, it seems like we have this neuronal network dysfunction happening years before we have symptoms of dementia, but also it's a consequence of the significant neuronal death and inflammation that comes later in the disease. So it's a really complex process from stages before dementia is being diagnosed, or like Alzheimer's or any other neurodegenerative diseases, but there is a different type of neuronal network dysfunction later during the disease process. So my lab, during the past 15 years, put significant effort understanding the excitatory inhibitory network dysfunction in Alzheimer's disease. At the moment, we have many labs focusing on this problem, but when I started the work 15 years ago, it wasn't really a thing. And even now, like most of our efforts, they go into amyloid tau targeting therapies, and but there are like some major efforts understanding more this imbalance and also finding new therapeutic targets to restore it. So when I started the work, like already we had the drugs, the cholinesterase inhibitors and the NMDA receptor antagonists. So kind of we know that targeting the excitatory side of the problem can provide some symptomatic relief for the disease, but not much research focused on the inhibitory system. The main reason was that after a couple of studies have been performed looking at the human Alzheimer's disease brain, it was concluded that GABAergic neurons are quite resistant to Alzheimer's pathology, and they are quite stable, and they are there, and most likely there is more problem on the excitatory side of this balance. But actually, I had to realize we were really diving deep into the inhibitory system and looking like how different receptors, transporters are being impacted by the disease. But actually, like on the excitatory side, like the glutamatergic system hasn't been really characterized well. And like we know the importance of the NMDA receptors in the process of excitotoxicity, but there are many other glutamate receptors which are involved in the pathology of Alzheimer's disease. So we put significant effort into this. We characterized these neurotransmitter systems in the mouse brain, but also in the human brain. And I remember this image. I was still an undergrad student, and it was just amazing to see that how some GABA receptors are very specifically expressed in the hippocampus only. And I think any pharmacologist who would look at this image and who is working on memory learning, like your heart just starts beating faster, you know, because like this is what you want to see, like you're such a restricted expression of a receptor. And especially like we know the alpha-5 type of GABA receptors, they are very important for memory function. So it's an ideal therapeutic target. And GABA receptors, they are pentamers. There are more than 20 subunits that can form this pentamer, and this alpha-5 is one of them. And they are part of a GABA type A receptor, which is extrasynaptic, and it can sense really low levels of GABA, ambient GABA levels. And it's very, very important in regulating tonic inhibition in the brain. And we know if the function of this receptor is impaired, that leads to LTP impairment and problems with memory. And very early studies, probably like 20 years ago, the alpha-5 subunit was knocked out from the mouse brain. And actually what was observed that those animals had improved cognition. So if we see probably the opposite upregulation of these receptors, that's not too helpful. And actually that's what we see in the human Alzheimer's disease brain. So actually when we performed these studies, we were mapping all different type of GABA receptors, subunits, and the expression throughout the Alzheimer's disease brain, mainly looking the different regions of the hippocampus and the temporal lobe. My main goal was looking the alpha-5 receptors, actually, that are they even present in the Alzheimer's disease human brain, because there is always a chance that one receptor is just so much downregulated that there is no point targeting with a drug in the disease. But actually we observed the opposite. In the CA1 region of the human hippocampus, we have seen this upregulation of the alpha-5 subunit. And based on animal studies, we know that itself, this upregulation is enough to impair cognition. So our aim of our studies was looking at the effect of amyloid beta in the mouse and human brain as well, and look at the how the functional activity of the neuronal network is changing after the administration of amyloid, and can we counteract these changes with alpha-5 type GABA receptor targeting drugs. So our hypothesis was that beta amyloid will alter neuronal activity due to the disrupted excitatory inhibitory balance in the brain, and then an alpha-5 subunit targeting drugs such as alpha-5 IA can reverse these changes. So we have chosen alpha-5 IA that time. These experiments, they started really the preliminary work 15 years ago, because I wanted to establish a model first, what we were using for these experiments, and then I had the opportunity to perform the human brain tissue experiments to validate our target. And then we also started the work with some in vitro studies, looking the effect in vitro of this drug. There have been that time other alpha-5 IA targeting drugs discovered, and this alpha-5 IA has been, the pharmacology was characterized by Professor John Attack and Merck. And it was the best compound that time. And we tested in vitro the drug in mouse hippocampal cultures. The reason was we were choosing this model because you apply amyloid beta to many cell lines, you don't see any effect because they are just not sensitive enough. And we fully characterized also these primary hippocampal neurons. We know that after 14 days in culture, they reach adult phenotype. We performed some RNA-based studies. We characterized the receptor types that are expressed, and they were showing that they show adult phenotype at that time. We treated the cells with amyloid and alpha-5 IA at 4 different concentrations. And what we have seen that amyloid, obviously, it's increasing significantly, the cell death, and the drug can prevent this cell death significantly. But what we also found in these primary neuronal cultures is what we have seen in the human brain, the upregulation of the alpha-5 subunit. And then this upregulation was prevented by the alpha-5 IA treatment. And here what I'm showing on the right, that's an ELISA result, because in vivo in the brain, it's impossible to measure ambient GABA levels, so that GABA that just goes through the extrasynaptic place. But here in the cultures, we collected the media, and then we could measure GABA levels with ELISA, and we have seen that amyloid is significantly increasing GABA levels, and alpha-5A can decrease this increase back to normal. So as a next step, we moved to in vivo experiments, and we decided to perform the behavioral testing and looking if the drug can improve cognitive performance in amyloid beta treated mice in aged animals, because Alzheimer's is the disease of age. And while now we published a couple of papers and we characterized the GABAergic signaling during aging, and we know that, for example, in the mouse there are really no changes at the expressional level. Spatial level, like one receptor, the alpha-2 containing subunits showed some differences, but it seems that the GABAergic system is very stable during aging. This is despite the assumptions, but those were only assumptions because there were no published results showing that there is like decline in the function or expression of the GABA receptors during aging. So we used 18-month-old mice. We injected them with amyloid beta into the hippocampus. We used ACSF as a vehicle. And then we performed a battery of different behavioral tasks because we were looking the effect of amyloid and the drug treatment on both spatial and non-spatial memory. And then you can see also the timeline of some electrophysiology experiments. I'm going to talk about that later, because the key point was really to see if we see behavioral improvements or not. We didn't go into details and look at mechanisms before we knew that the drug actually is helpful to prevent cognitive impairment. So this is actually the most important outcome of all the behavioral tasks. We performed a simple novel object recognition task when we present the animals with two identical objects. After 24 hours, we replace one of the objects, and mice are really curious creatures. They will spend more time observing the new object. And then here you can see the significant decline in the discrimination ratio in the amyloid beta treated animals, and that was improved by the drug treatment. So this is just really getting through the message that spatial memory was able to restored with the drug treatment. But here is like the summary of all the behavioral tasks that we performed. Besides the novel object recognition task, we also performed the novel object alteration task when we changed the location of the objects. So the same object stays after 24 hours in the arena, but we move it to a different location. And we see the same improvement by the drug. And we know that there is impairment by amyloid. This is being restored. We tested two different concentrations of the doses of the drug, and both were effective. And we knew from before that amyloid is not impairing short-term spatial memory, and that was tested by the Y maze. And we also performed for anxiety. We used the O maze, and we didn't see any differences between any of the groups. But we also do, like during the different like novel object recognition alteration task, we record the movement of the animals, their speed, and we see that they don't show any signs of anxiety. And we also perform the water maze test because that's like a gold standard for spatial memory testing. And we could get like multiple different parameters, and here on the right you can see as they learn day by day. We do 3 trials. So basically we put the animal into the swimming arena, and then there is a platform, and the animal is improving every day, and through each trial, they find the platform more faster. And then we are looking like how much time the animal will spend in the platform quadrant, and then we can see that the amyloid beta impairs this behavior, and the drug can bring it back to normal. So after we had evidence that alpha-5 can restore cognitive performance, we moved into electrophysiology studies. At the beginning, we have shown the effect of amyloid, and we found that amyloid can increase tonic inhibition in the hippocampus. So what we did, we used younger animals because we can't do voltage clamp in old 18-month-old animals. So we injected them, just like for the behavioral experiments with amyloid beta, into the hippocampus, and then we have been waiting for 7 days. We have behavioral testing results from 7 days as well. We see that there is impairment at that time already. And then we prepared the slices and we patched the neurons, the CA1 pyramidal neurons in the hippocampus, and then we applied the drug during the recording. So at the beginning, we are recording 5-minute baseline. After that, we apply bicuculin, and this allows us just to measure the tonic inhibitory component, and it's the indication of the tonic conductance in the system. And then you can see that with the drug in the blue, we were able to restore the tonic inhibitory conductance. So this is not surprising, like based on the drug's pharmacology, this is what's supposed to happen, but we had to show that actually this is happening. And what we also have done, we did some histology in the end, and what you can see on the bottom, those are pyramidal neurons in the CA1 hippocampal region, and you see the perfectly healthy cells in the naive control mice. There is a little bit of damage in the ACSF group because we are injecting amyloid into that area, but that's not significant. And then with amyloid beta, we see a significant cell death. And then you look at the drug-treated group, there is still a significant neuronal death. This doesn't mean that the drug doesn't have the potential to prevent cell death. This is just something that comes with the model because we are injecting amyloid, and it takes for our drug to reach plasma concentration a couple of hours. And amyloid's effect, once you inject it to the brain, it's super fast. So even when in vivo we applied, if you remember, amyloid and the drug together at the same time, but here there is a delay, and by the time the drug can probably act, there is already such a damage that we can't basically fix that problem. But actually, this was our goal because this model is more realistic in a way. We were not planning to come up with a preventative model here, because in real life we will have some damage already in the brain of people with Alzheimer's disease. And in this case, even if there is cell death, we can still restore cognitive performance. We can see that based on these results. So by restoring network activity. So as a next step, we moved to brain slices and we performed some microarray experiments. This is really an efficient way to measure LTP because, as I mentioned, there is like plenty of evidence that amyloid causes deficits in LTP, and but we can look at other parameters as well with these microarray experiments. I have to emphasize here, and we have written a review about this just based on ME experiments, that depending what type of amyloid you are applying in your experiments, what is your concentration, how long you apply it, the effects can be very variable, especially if we are looking excitability, spontaneous activity. But when we are looking amyloid's effect on LTP, that's always the same, and we see, of course, within a certain concentration range, we see impairments in LTP. So the main parameters, what we were looking, it was input-output curves when we are increasing the voltage from 0 to 5 millivolt, and then we are looking at the amplitudes of the responses, and we have our LTP protocol, after recording a baseline, we are delivering a fast theta burst activation stimulus, and then we keep recording for at least 2 more hours. And then we also do like a pair pulse measurement, and this is the indication of short-term plasticity. Here you can see the microelectrode arrays. Yeah, I'm finishing. And we didn't find a significant increase in excitability, but there is a significant trend. But here you can see on the graph, that amyloid impairs LTP, and the drug can restore the LTP deficit. And we didn't find significant differences in the short-term plasticity. So what we have shown, alpha-5 can restore LTP and tonic inhibition and cognitive abilities in amyloid beta injected mice. However, alpha-5 IV is not suitable for chronic dosing in human. That came through some clinical trials. It causes kidney toxicity. It's not surprising because it's very difficult to dissolve the drug, and that is a problem. But the good news is there are some really good drugs now, and we are testing them. And we see similar results as with alpha-5 IA, and some of them are already in clinical trials, but not for Alzheimer's. But we are hoping, that if there are no issues with toxicity or any problems, and if those trials are going well, then there is a hope that we could do some work in Alzheimer's as well. So next steps, we're really interested in the chronic effect of this drug, and as I mentioned, testing other compounds as well, and then moving to in vivo studies and mainly clinical trials. And I just would like to acknowledge everyone who was involved in this work. This work started back in New Zealand before I moved to Ireland in 2022, and then we finished the final ME experiments here, and we started testing some new drugs. And thank you for my research group. And also, as soon as I moved to Ireland, I immediately joined AAP, and I'm looking forward working with you in the future as well. Thank you everyone for listening.
So, in the interest of time, we might not have time for a question, if you're okay. But you may talk to her after the wrap-up of this session, because we have another last speaker. So our final speaker is Dr. Maria Principe, Assistant Professor of Pharmacology at University College Dublin and co-lead of the Cancer Biology and Therapeutics Laboratory at the UCT Conway Institute. For me, it's a particular pleasure to introduce Maria because she's one of my most long-standing colleagues and good friend at UCD. Her research focuses on understanding resistance to hormone therapy in breast and prostate cancer with the aim of developing more effective treatments and companion diagnostics. She's also actively involved in national cancer research leadership and an advocate for patient and public involvement in research. Her talk is about exploiting the synergistic effect of targeting key proteins in the androgen receptor signaling pathways for the treatment of prostate cancer. So welcome, Maria.
Many thanks, Monica, for the kind introduction and for the invitation to speak today at this great conference. So just a disclosure, I am not a pharmacologist by training, so hopefully you won't hold that against me. But what we do in my lab is looking for novel drugs and combinations for hormone-driven cancers, including prostate cancer. So prostate cancer is the second most diagnosed cancer worldwide in men and a leading cause of cancer-related deaths. 1 in 7 men will be diagnosed within their lifetime. The good news is that 80% of these men have the localized form of the disease, and so the survival rates are quite good. However, for the 20% who progress or present with metastatic prostate cancer, the survival rates drop significantly, and this is why we need better treatments for this cohort of patients. Androgen signaling is very important for the prostate gland, and it becomes also hijacked in prostate cancer. So androgens such as testosterone will enter the cytoplasm, be converted into DHT, the potent and active form of testosterone, bind the androgen receptor, which dimerizes and translocates to the nucleus. AR is a transcription factor, which will then initiate transcriptional programs which drive which drives prostate cancer progression. And so the main therapy for advanced and metastatic prostate cancer is androgen deprivation therapy by either removing the androgens or targeting the androgen receptor. So in terms of clinical management of prostate cancer, for locally advanced prostate cancer, as I said, androgen deprivation therapy, ADT, is the main strategy, and we have different flavors here, either alone or with androgen receptor antagonists such as enzalutamide or with chemotherapy. And these treatments work reasonably well for a period of time. However, over time, virtually all men will develop resistance to these treatments. And now they develop a most aggressive form of prostate cancer, which is known as castrate-resistant prostate cancer, which is incurable. So the treatments that we have available for these patients are only palliative. We still use some form of androgen deprivation therapy or targeting the androgen receptor, but mainly chemotherapy is used, usually taxanes. And so there is an urgent need to find better treatments for these patients. The mechanism of resistance to this ADT therapy are several and mainly revolve around the androgen receptor. And so we have AR amplification and splice variants, which lack the ligand binding domain. We have promiscuous pathways whereby the androgen receptor can be activated by other ligands. And the mechanism that my lab focuses on is really the involvement of AR regulators. One such AR regulators that my group and other groups discovered is the serum response factor, or SRF. SRF is a transcription factor which is involved in many cellular processes relevant to cancer via two main pathways, the Rho and the RAS pathways, through co-activators. And basically when it binds to the responsive elements, it drives two main pathways involved in metastases and in cell cycle regulation. And over the years, we have found that there is a crosstalk between SRF and AR, especially in castrate-resistant prostate cancer. My lab particularly has worked on this for a decade now, and we have stained many patient samples, tissue cohorts with SRF antibodies using immunohistochemistry, and I found that high SRF expression is associated with prostate cancer prognosis and poor survival, and most importantly, with resistance to enzalutamide, which is one of those therapies used for castrate-resistant prostate cancer. And so we really think that this could be an alternative molecular target, either singly or in combination with targeting AR itself or other pathways. So to do a bit of functional studies around inhibiting SRF, we are using several compounds. Two compounds belong to the CCG series of compounds. These are CCG 1423 and 257081. And these do not target SRF directly, but they target its transcriptional activity by inhibiting MRTF, which is an important cofactor of SRF. And then the other inhibitor that we are using is lasturtinib, which is a PKN1 inhibitors, which convey androgen responsiveness to SRF. And also lasturtinib does not target SRF directly, but again, through inhibiting the transcriptional activity of this transcription factor. And lasturtinib is quite interesting because it has already been tested in humans through clinical trials. It has shown some promise. And so if we can show promising in vitro finding and preclinical finding, then this could be easily translated into the clinic. Okay, so when I started to work on SRF a few years ago, I started from an isogenic cell line model of castrate-resistant prostate cancer. We worked on the LNCAP parental cell line, which are androgen deprivation treatment sensitive. And then we work with the ABLE, which are basically the parental grown without androgen. So they're derived from the parental and they are resistant. So we treated them with these three compounds which inhibit SRF. And if you look at the black bars, which are the parental line, so the sensitive cells, you can see that the IC50 values, and these are viability assays, for enzalutamide, which is the gold standard, are very similar to the CCG compounds, and the lasturtinib has significantly lower IC50 value. So already for androgen sensitive, for a model of androgen sensitive prostate cancer, inhibiting SRF has some values because when you have resistance, you have another option to target something else. But what was interesting was the ABLE, so the resistant cell lines, which have higher IC50 for enzalutamide than the parental because they're resistant, but then these drop significantly for the inhibition of SRF. So as I said, this was promising, but we next wanted to look at combinations, combining SRF and AR inhibition, because as I said, we had found a crosstalk between the two pathways. We did that in both cell lines using CCG 1423 and lasturtinib. And as you can see, combining the two brought the IC50 for enzalutamide significantly down across the board. Next, we tested this combination of CCG 1423 and enzalutamide in patient-derived xenograft mice. This was a collaboration with the University of Washington, where they have a panel of PDX, which are taken from a rapid autopsy program from patients with prostate cancer. And what we found was, again, that there was basically our in vitro findings were confirmed. There was a significant drop in tumor volume using ENZA, CCG alone, and combination. This was reflected in the PSA, which is a biomarker of response to treatment, and also the survival for the combination was better than the single treatment. Next, we took these tissues from the PDX mice which had been treated with the drugs and stained them for the androgen receptor. So you can see here the control vehicle is all brown, and the AR is mainly in the nucleus, but also in the cytoplasm. When we treat it with enzalutamide, we have the expected outcome of the androgen receptor being inhibited from translocating to the nucleus. But what was very surprising, and we were actually very happy to see this, was that CCG and the combination had a similar effect to enzalutamide. In fact, it was even more pronounced. So after a decade working with SRF and SRF inhibition, if I had to pinpoint one single experiment that I am very excited about, this would be it, because here we're showing that we can inhibit SRF and have an effect on AR, which, as I told you, is the main target for prostate cancer, but also the main source of resistance. And so if we can inhibit AR translocation by inhibiting SRF, we could bypass the resistant mechanisms. Okay, but how is this happening? How is SRF inhibiting AR translocation to the nucleus? We did a mass spec after co-immunoprecipitation of SRF and AR to look at common interactors. Maybe those common interactors were the key to this crosstalk and to the effect of SRF on AR. I'm not going to go into the details of that study. It's published. If you're interested, you can read the paper. But this is just a summary of the study and a summary of all the pathways that are in common between SRF and AR. And we have unfolded protein response, DNA damage response, nuclear transport, very important. And by the way, we are working on RAN at the moment to look at this nuclear translocation and how RAN could be involved into that, and also the PI3K-AKT pathway. So what we did then was some functional validation of these results. We picked selected proteins in those pathways for which we had some drugs available, and we treated a panel of prostate cancer cell lines with these drugs singly and in combination. So I've already talked about the SRF inhibitors. We also used enzalutamide to inhibit AR, and enzalutamide, again, is the gold standard, what's used in the clinic, and also another compound which inhibits an AR variant which is lacking the ligand binding domain, and it is very important clinically because it arises after androgen ablation treatment. So it's one of the mechanisms of resistance. And then we picked some of the common cofactors and inhibited them as well. So this is a table summarizing a lot of work from a couple of PhD students. So we have the inhibitors here, the panel of prostate cancer cell line, the parental are the sensitive ones, and then these three are resistant, and the 22RV1 also harbor the ARV7 variant. So if I can draw your attention on the enzalutamide IC50s, you will notice that, especially for the resistant cell lines, the IC50 values for both compounds, CCG and LESTA, are significantly lower than those of enzalutamide. And so, again, this is encouraging. And this was true across the board for all the other inhibitors. But as I said, we're also looking at combinations. So next, we did a panel of combinations in the 22RV1 cell line, which is the one that harbors the splice variant. And across the board, we noticed that the combination were better at decreasing cell proliferation than the single treatments. So just to point to one example, this is, I can't read, CCG plus EPI, so SRF and AR variant. And these are the single treatments, and the combination is much lower in terms of viability. Next, we wanted to see whether these combinations were having an additive or synergistic effects. And so for that, we used a couple of software, actually. I'm showing here the CompuSyn analysis, and the green is synergy, the red is antagonism, and then there is something in between. As you can see, there is a lot of synergy in these combinations. And by the way, we tested the IC50 safety of the two drugs, but we also went down and tested IC30 and IC10 with the idea that if you can use lower concentrations of these drugs in combination, you could also have kinder treatments and less side effects for patients. And in fact, we were delighted to see that even at the lowest combinations, the 2 IC10, the synergy was maintained. And this was also true for a second cell line, the C4. Again, these are castrate-resistant, and this is important because prostate cancer is highly heterogeneous, and so to show the same thing in a couple of cell lines is encouraging. The last couple of slides, I'm going to show you things that we are currently implementing and where we want to go with this. So we want to validate these in vitro findings in an in vivo system, and Kim Zitzman, one of the PhD in the lab, is developing this zebrafish xenograft where she injects prostate cancer cell line in the zebrafish and then treat with several combinations and follow migration and survival of these cells. And the reason why we picked the zebrafish is that I'm going to laugh now because I always say we want to do something quick and dirty to test as many combinations as possible. It's not that quick, I'm going to tell you. It is a bit dirty, but not that quick. But anyway, the idea was to do something quick, and then the best combinations to bring them forward, perhaps into mice. So just a couple of images from Kim preliminary experiments. These are the cancer cells injected in the perivitelline space. And then after 24, 48, and 70 hours, if you look at them under the fluorescent microscope, you can see that there is migration in the head, but also in the tail of these prostate cancer cells. And so this is going to be a very nice model to look at, yes, survival, but especially migration of these cells. And finally, we are currently working to develop patient-derived organoids. These are tiny balls of cells derived from tissues from patients, which maintain the original architecture, the genetic makeup of the patient. And we are developing a panel of these patient-derived organoids. And again, the idea is to test these treatments and combinations on this panel of organoids. And I'm showing here just a pilot that was done in collaboration with University of Bern. And again, this validates and is in line with our in vitro experiments. You can see here, this is a sensitive line, and this is a resistant line. This is enzalutamide, so the organoids are sensitive to enzalutamide, resistant to it. And when we treat it with CCG, which is the SRF inhibitor, you can see that there is a similar response to enzalutamide, but here they were resistant to enzalutamide, and they're now dying with CCG. And then in red, you have the combination, and again, you can see that it is more effective than the single treatment. So in summary, we have shown that SRF and AR common pathways could function as therapeutic targets. We showed synergistic effects using combinations of these drugs. We think that a possible mechanism by which there is this synergy could be that SRF inhibition affects AR translocation to the nucleus. And we are looking forward to validate these findings in vivo and in patient-derived organoids. I'd like to thank the people who did most of the work, especially Kim Zitzman, who is driving the zebrafish and the synergy study, all the collaborations, internal and external, the cancer biology and therapeutic lab, the funding agencies, and thank you all for your attention.
Thank you, Maria, for this very elegant presentation. We might just have time for one quick question from the audience, if anyone has. Or else I'll just ask you. So it looks from your data that you are selecting a more potent some of these drugs with lower IC50 and some of synergistic combined therapy. So are you expecting a novel therapy based on this to be more effective or also less side effects or a bit of both?
A bit of both. We want to strike jackpot. Basically using either single treatments which are more potent or using them in combination really to have kinder treatments for patients if we can use lower doses. And also SRF is a very widespread transcription factor. We've shown that it is upregulated in prostate cancer and the most aggressive prostate cancer, but we don't have ways at the moment to directly target SRF. So if we can find in that pathway something which is more amenable for targeting, then that's even better.
Yeah. Okay. Thank you very much. So again, thanks to Maria. I'd just like to wrap up this session and thanks all the speakers and Pat Mori for being here. And again, thank you on behalf of the Irish Association of Pharmacologists for this Irish Symposium.
Thank you.